All right, so we are still talking about clotting issues here. Hemophilia, you guys will probably talk about this in pediatrics, so you'll get a double dose of it this year on it. Hemophilia, this is a hereditary bleeding disorder that results from a lack of specific clotting factors, and it occurs in two main forms. Now, there's other types out there, but the two main ones we're going to talk about are going to be hemophilia A, which is known as your classic hemophilia. That's going to be seen in more than 80% of your hemophilia cases. That results in a deficiency of factor VIII. Okay, so these are Roman numerals. This is how it's always expressed. So if you guys don't know how to read Roman numerals, talk to me and I'll make sure that you guys understand it. But this is how it's written out. Hemophilia B, this is also known as Christmas disease. It accounts for roughly 15% of your hemophilia cases, and that's going to result from a deficiency in factor IX. Okay, so hemophilia A, that's your factor VIII deficiency. Hemophilia B, that's your factor IX deficiency. This is completely hereditary, okay? And treatment advances have greatly improved your prognosis of individuals with hemophilia. And many hemophiliacs now have normal lifespans. Surgery can be done safely under hematologist guidance for special hemophilia treatment centers. Okay, so whereas this used to be a death sentence for people, decades and decades ago, individuals with hemophilia can lead relatively normal lives now as long as they adhere to the regimens, advised by their doctors. So, what this is we're dealing with abnormal bleeding, and I want you guys to understand that this is inherited. Okay, it means that the female carriers have a 50% chance of transmitting the gene to each son or daughter. Daughters who receive the gene are carriers. Sons who receive it are born with hemophilia. Okay, so daughters are carriers, whereas the sons are the ones that are going to be born with hemophilia. Okay. What you're going to see is you're going to see abnormal bleeding. Okay, so it depends. It depends on, are we dealing with mild, are we dealing with moderate, or are we dealing with severe hemophilia? So for your mild hemophilia, bleeding doesn't occur spontaneously or after minor trauma. However, major trauma or surgery typically cause prolonged bleeding. So for your mild hemophiliacs, they don't usually have a whole lot of complications with it. Your moderate hemophiliacs, they have spontaneous bleeding occasionally, with surgery or trauma causing excessive bleeding. And with your severe hemophiliacs, these are the ones that bleeding occurs spontaneously, maybe severe, even with minor trauma, leading to large subcutaneous and deep hematomas within the body. So the major or the severe hemophiliacs are the ones that, most of us think of, when we're talking about hemophilia. But understand, hemophilia can be mild, moderate, or severe. So you may see bleeding into the joints and muscles. That can also occur. It causes pain, it causes swelling, extreme tenderness, and possibly even deformity of some of these joints, okay? And then the worst thing that we worry about, of course, is bleeding into the brain. So that's, the worst complication of hemophilia that we could see. So diagnostic-wise, when we're looking at patients with hemophilia A, you're going to look for a specific factor VIII assay, okay? You'll also see a prolonged PTT, and we'll look at their platelet counts, we'll look at their bleeding time, and their PT levels. For hemophilia B, we're going to look at factor IX assays, okay? So they'll be deficient in whatever factor level they're missing. And then we'll also look at, just like for for hemophilia A, we'll look at their PTT levels, bleeding time, and a PT. So even though hemophilia isn't curable, treatment can prevent crippling deformities and prolong life expectancy. So correct treatment quickly stops bleeding by increasing plasma levels of deficient clotting factors, and it helps prevent disabling deformities that result from repeated bleeding into the muscles and the joints. So for your hemophilia A, for example, they're going to give they're going to give that factor VIII, okay? Fresh frozen plasma is sometimes also given. For our patients with hemophilia B, we're going to give them factor IX infusions, okay? You also may require Desmopressin, it can be given to stimulate the release of stored factor VIII, raising the blood level of that factor. In hemophilia B, you administer factor IX, concentrate during bleeding episodes to increase those factor IX levels. So desmopressin is usually going to be reserved for your patients with hemophilia A, okay, in addition to their clotting factor VIII. Whereas usually hemophilia B doesn't always require desmopressin. Both of these patients may require transfusions too, okay? So it's very important that we identify whatever type of hemophilia we're dealing with and replace the appropriate clotting factor that goes with it. What you're going to do during bleeding episodes is you're going to administer the deficient clotting factor or plasma. The infusion is always given as an IV. We don't give it as an IM injection. We will sometimes apply cold compresses or ice bags and elevate the injured part. To prevent recurrent bleeding, you want to restrict the patient's activity for 48 hours after bleeding is under control. If bleeding into the joint occurs, you want to immediately elevate the affected joint. We control pain with an analgesic. A lot of times we'll use acetaminophen, codeine. We know that any aspirin or aspirin-containing medications are going to be contraindicated. No IM injections for these patients. After bleeding episodes and surgery, you want to watch closely for any signs of further bleeding. We're going to closely monitor their PTT level. To restore mobility of an affected joint, you want to begin range of motion exercises and tell the patient to avoid bearing weight on the joint until bleeding stops and the swelling subsides. So nursing diagnoses for this patient, pain is a big one. Ineffective protection, that's a huge one for this individual. And I love risk for ineffective self-health management. I talk about this a lot in pediatrics, especially when you're dealing with your adolescent. As you get to these risk-taking behaviors or the ages where they want to take more risks, you have to be worried about ineffective protection and can they protect themselves against, further complications. So this is not a patient that you would advise them to play football, for example. You don't want them playing contact sports, especially like a severe hemophiliac, because they can die from that. So we still talk to them about, what are appropriate recreational activities they can do. So swimming is always a sport that you tend to kind of steer them towards. You want to make sure that if they are going to ride bikes that they have the helmets and the knee pads and the elbow pads and all the protective equipment necessary. So make sure that we lots and lots of teaching, because again we're trying to protect this patient at all costs, especially if we're dealing with a more moderate or a severe hemophiliac. They can die very, very quickly if they are not protected at all costs. Okay, so that's why risk for ineffective self-health management is also tied to this patient, because especially if we're dealing with someone who engages in risk-taking behaviors for a hemophiliac, it could be potentially deadly. Okay, that is it on hemophilia.